chemotherapy. This year, it's just 3 different topics that I thought were interesting from what's gone on this year in the literature and then at meetings. So this is the outline. We're going to talk a little bit about small cell lung cancer because the therapies that we've been, the standard first-line therapy for small cell lung cancer has been the same since the 1980s. And that has recently changed as far as December of this year. We're going to talk a little bit about pancreas cancer because finally we have biomarker-based therapy. And then there's an interesting presentation at ASCO about the Affordable Care Act. And then this is a plug for our annual oncology update. It's going to be a week from Saturday in Fort Lauderdale. And if anybody would like to come, I know a guy can get you in pretty easy if you want. So, all right. So let's talk a little bit about small cell lung cancer. If you think about lung cancer, when it's the most common malignancy diagnosed in the U.S., 228,000 a year. The next, I believe 3 cancers don't all add up to equal lung cancer. As far as small cell lung cancer is concerned, it makes up about 15% of the total cases of lung cancer that are diagnosed in the U.S. And small cell lung cancer has some specific features that I'll talk about on the next slide. So again, about 29,000 annual cases in the U.S., almost exclusively in smokers. The thing that we talk about when we think about small cell lung cancer is that it's considered a very fast-growing and aggressive malignancy. It's got fast doubling times, the high growth fraction. It tends to be very chemotherapy responsive. However, patients do develop resistance to that chemotherapy fairly rapidly, and still we don't cure a lot of patients. About 5% of all the patients that are ever diagnosed with small cell lung cancer are alive at 5 years. But if you have limited stage disease, your odds are a little bit better. But again, it's a terrible disease overall, and it's one, as I said, very chemotherapy sensitive, but also people relapse quite quickly. It's considered a systemic disease at the time of diagnosis. And again, it's a small blue cell tumor. It does stain for some epithelial markers, but also neuroendocrine markers when you're doing the immunohistochemistry on these cancers. All right, so this is the first study that I could find. This is from 1985. The first study that I could find that helped to define the standard of care chemotherapy, frontline chemotherapy for patients with extensive stage small cell lung cancer. Now, they had some limited stage patients in this as well. Relatively small study. Again, you're looking at a total number of patients of about 28. They had an observed objective response rate of 86%. I think now when we consider this particular regimen, we think about response rates in the 60s to 70s, and the median survival hasn't changed very much. And then this is our survival curves looking at the different, limited stage versus extensive stage. But this was one of the papers that helped to establish a standard of care. So cisplatin etoposide, or carboplatin etoposide, more recently carboplatin and cisplatin have been shown that they're essentially equivalent. I believe there's a meta-analysis in 2012 that established that. But anyway, etoposide and some type of platinum has been the standard therapy since about 1985. And we haven't made a whole lot of progress in there. So when you think about to 1985, what was going on in 1985? So President Reagan, the big news story was Mikhail Gorbachev becoming the Soviet leader. Back to the Future, Careless Whisper with Wham, Cosby Show, I'm not going to make any more comments, and Live Aid, I remember Live Aid happening, and then I graduated from high school. I was pretty happy with my mustache at the time, if I remember right, but anyway, that was what was going on in 1985. So that was almost 35 years ago. So the fact that the standard of care for small cell lung cancer frontline has not changed in 35 years, this is a big deal. So almost every time we talk about immunotherapy, this slide goes up. And it's because it's highlighting which tumors have a high mutational burden and which ones don't. And you can see that small cell lung cancer is on the high end. And so we would expect that immunotherapy might have a role there. Why do we expect that? Because if you have a lot of somatic mutations, you're then making these unusual proteins. These unusual proteins are antigens. And the more unusual antigens that you have, the more likely you are to have some type of immune response. We now know that if we have our tumor cell interacting with our T cell here, when the tumor cells interact with the T cells, PD-1 interacts with PD-L1, that turns off the T cell. So even though it's getting stimulation from a new antigen, the T cell is not going to kill the tumor cell because this PD-1, PD-L1 interaction is maintained. However, when we have a PD-1 or PD-L1 blocker, it interrupts this interaction, and now the T cells are activated and able to kill the offending cancer cell. But the more novel antigens that you have, the more likely it is that immunotherapy will work for you. So this was a first-line study of atezolizumab, which is a PD-L1 inhibitor, and it was being given to patients along with chemotherapy in frontline therapy for extensive stage small cell lung cancer. So this is it's called the Empower 133 study, and this is the schema that they had patients with, again, extensive stage small cell lung cancer. They were randomized 1-to-1 to receive atezolizumab, which is a PD-L1 inhibitor, along with chemotherapy, and then they went on to atezolizumab maintenance therapy, and the other group got carboplatin and etoposide, which again has been around since the 1980s, and they were, their maintenance therapy was a placebo, and these are the key outcome measures that they were looking at. This is the flow of patients, but basically the reason why we want to combine immunotherapy and chemotherapy, and then this goes against a dogma that was present some years ago, was that you didn't want to combine immunotherapy and chemotherapy because the chemotherapy could reduce the amount of immune cells that are around, and so you can't really activate immunotherapy. That has not been the case, in that chemotherapy and immunotherapy can combine reasonably well, especially non-small cell lung cancer, and some other malignancies as well. So the chemotherapy may actually help you may form additional tumor antigens so that the T cells have more things to recognize. So immunotherapies have shown clinical activity in advanced small cell lung cancer. So again, it made some sense to combine chemotherapy with the immunotherapy, and that's what they did in this particular study. And so these are the outcomes. They had approximately 200 patients in each group. They did see the complete response rate was relatively low, but they did see a reasonable partial response rate. As I mentioned in the original study, it was something like 80%. And I said overall in practice, we'd see, I think 65, 67% is typically what we'd expect with small cell lung cancer, and that's about what they saw. The important thing was that as far as disease progression was concerned, the amount of disease progression on the immunotherapy arm was better than the chemotherapy alone. So if we look at overall the curves here, the curves are separating, and so we are seeing that adding atezolizumab to carboplatin and etoposide, patients had longer overall survival, 12.3 versus 10.3 months. The response rates weren't necessarily that different compared to the placebo group. But as far as overall survival is concerned, there was a difference. Now, people could argue that the atezolizumab is being kept as a maintenance therapy, and so you're actually giving these people therapy where the placebo group is not. And that can be a potential criticism of this type of study. But overall, as I said, it's something that for small cell lung cancer, it is something that we need to consider as one of the standard frontline therapies for this particular malignancy. All right, moving on to another tough one. Pancreatic cancer. Overall, there are about just 56,000 cases of pancreas cancer diagnosed in the United States. The death rate is fairly high. Only 9% of patients who are diagnosed with pancreas cancer are alive at 5 years. It doesn't matter what stage you are, approximately 9% are going to be alive at 5 years with pancreas cancer overall. As you can imagine, the outcomes are worse the higher stage that your cancer is diagnosed at. If 100 patients with pancreas cancer show up, there's going to be only about 20% of them can actually go on to have immediate surgery. And even now, we're even talking about doing chemotherapy in these patients anyway. Only about 20% of them can actually go on to have surgery. Only a small percentage of those, the majority of those are actually resectable, but a small percentage are cured. Even if you have surgery, about 7 out of 10, it's coming back. That cancer is coming back. And so it is a cancer that's very difficult to cure. We do, I would say here at University of Miami, we see a fair number of these patients that we try to convert with chemotherapy to try to make them resectable. That's one of the things that we work on. But this particular study that I'm going to talk about in pancreas cancer has to do in the metastatic setting, which again is a fairly large proportion of the patients that we do see who walk into the clinic with a new diagnosis of pancreatic cancer. So we have two frontline standard of care chemotherapy options. One of them is FOLFIRINOX, which is a regimen consisting of 5-FU, leucovorin, oxaliplatin, and irinotecan. That's not going to be a test on that. And then the other regimen is gemcitabine and nab-paclitaxel. You can see here the median overall survival is 11.1 versus 8.5. You would think it would be obvious that you would use this one, but you don't necessarily, that's not necessarily the case. FOLFIRINOX is a lot tougher regimen to handle for a lot of the patients. You need fairly robust patients to be able to handle FOLFIRINOX. You can't just give it to anybody. Gemcitabine nab-paclitaxel is better tolerated overall as, from a side effect standpoint. But again, we usually pick one or the other when we are administering frontline chemotherapy. So this particular study now was maintenance therapy, adding olaparib, which is a PARP inhibitor, to the frontline therapy for patients with metastatic pancreas cancer. So if you have 100 patients with pancreatic cancer, somewhere around 5% of them will have a BRCA1 or BRCA2 mutation. So again, a relatively small number, but we do see it. They tend to have increased benefit from platinum-based chemotherapy. If we remember our two different arms there, FOLFIRINOX has a platinum, gemcitabine Abraxane does not have a platinum. And what we're trying to find here is if by targeting this, are we able to come up with a maintenance regimen so that patients don't have to be on chemotherapy for life to try to, again, while maintaining their quality of life, can we give them some type of maintenance therapy that's not too toxic and can maintain whatever benefit they seem to be getting out of the chemotherapy. And to date, there are no targeted treatments in a biomarker-selected population for patients with pancreas cancer. So brief words about BRCA mutations. BRCA1 and BRCA2 are tumor suppressor genes. You do see mutations in them. The mutations can be of variable impact. There are some that are high impact in that they increase the risk of breast cancer, say 5%, and risk of ovarian cancer 10 to 30, I mean, that's not 30%, 5 times or 10 to 30 times as far as increasing risk goes. Some of the mutations tend to have no impact that we can figure out, but it is a relatively common scenario in breast cancer patients and ovarian cancer patients that we test for this. We see these, again, about 5% of the time in pancreas cancer, and we think that the risk of pancreas cancer in people with germline mutations of BRCA1 and BRCA2 is the increase is about three times, but again, it's much more well described in breast cancer. And again, it accounts for about 5 to 10% of breast cancer cases. The idea here, though, is that BRCA normally is involved in the DNA repair process. So, PARP inhibitors. PARP inhibitors are, PARP is part of the process that helps to repair DNA damage. So if you have DNA damage, you then, usually through the base excision repair system, you can repair the DNA damage and the cell survives. If you have, in this setting, if you have a PARP inhibitor, then PARP can't get in there to actually do the repair, so the cell should die. We're now combining a PARP inhibitor, which is inhibiting the repairs, plus somebody who is BRCA deficient, they should also have trouble making repairs to DNA damage. So combining a PARP inhibitor and somebody who is BRCA deficient, it should make those tumors more susceptible to being unable to repair the damage that they may incur. So this was a study design. They randomized patients with metastatic pancreas cancer. They've had a platinum agent, so most of them are going to have FOLFIRINOX. Some of them would have had FOLFOX, but they had to have a platinum agent. They had to be stable on the platinum agent, and then they were randomized to receive olaparib, which is a PARP inhibitor, versus placebo. And then this was carried, they were followed until they had either toxicity or disease progression. And overall, what they saw was that the patients receiving olaparib, their progression-free survival was improved compared to those receiving placebo. So overall, this was their hypothesis that they could come up with a maintenance therapy that they thought could extend the period of time that these patients are receiving some type of maintenance therapy, and that seemed to be successful. At every time point, 6 months, 12 months, 18 months, 24 months, the patients receiving olaparib had not progressed compared to those receiving placebo. And the quality of life measurements, I'm not showing it on here, the quality of life measurements were acceptable, such that olaparib was not causing a whole lot of toxicity. So maintenance therapy with olaparib provides meaningful improvement in progression-free survival for patients with germline BRCA mutations. health-related quality of life was maintained with this. And so now it should be part of the standard of care that we do germline BRCA testing on patients with pancreas cancer. And this is the first trial in pancreas cancer to validate a targeted biomarker that seems to have an impact on any of the meaningful clinical outcomes. Okay, last one. So now we're going to talk briefly about the Affordable Care Act. And this is getting a little bit into health disparities. So the Affordable Care Act, the official name is the Patient Protection and Affordable Care Act. It is also widely known as Obamacare, enacted by the 111th Congress back in 2010. The overall goals were to improve access, quality, and equity. There were insurance expansion and subsidies, allowed states to expand Medicaid coverage for adults, and then also there were these marketplace, private insurance marketplaces that people could subscribe to. All right, so what this particular study was looking at was seeing whether putting into place, having specifically the Medicaid expansion, because certain states expanded, certain states did not. And so you're able to potentially compare some outcomes in different states from those that expanded and those that did not expand Medicaid. They had a particular hypothesis that they wanted to look at in this case. So their hypothesis was that Medicaid expansion reduced disparity in the timely treatment of patients, black patients versus white patients with advanced cancer. So if you think about cancer, there's the prevention, the screening. From the time of diagnosis to the time of treatment, this is the particular window of opportunity that they were looking at. They were not looking at health-related outcomes, and I'll discuss that in a moment, but that's one of the limitations of the study. But they wanted to look at this, because if you look at overall numbers, there is an approximate number where you think it's within a window that you think it's reasonable from the time of diagnosis to the time of initiating treatment, what's reasonable for patients, and does that change based on race, and does that change based on whether a state has Medicaid expansion or not? So the databases that they use, this is from the Kaiser Family Foundation. These are the states that have Medicaid expansion, and there are ones that don't. So if you look at the blue states, those have Medicaid expansion, the ones that gray did not. Flatiron is one of these big data companies and they have health network practices around the country. These are the states that have the health network, Flatiron Health Networks, and so these could be overlaid. So then you could see you have medical records and data from Flatiron, and then you have the states that expanded Medicaid and those that did not, and then so now you're able to look at outcomes from using the Flatiron data from the states that expanded, states that didn't, and then also look at, since you have demographic information as well as some other information, you're able to look at potential outcomes of these patients. So they ended up examining around 30,000 patients, and where they had 18,000 in the states that Medicaid was not expanded, and you had 11,000 states that did, and you have male versus female, you have white versus black, and these are the particular kinds of cancers that they looked at. And again, they're looking at time from diagnosis to when therapy was initiated. So this is the change in racial disparity. So in the states that, again, when you think about the timeliness of starting therapy between diagnosis and treatment, in the states that were not expanded, the 48% of the white patients they thought were actually got treatment in a timely fashion, whereas in the black patients, 43.5. In the states where it was expanded, that gap was reduced, and this was found to be statistically significant in that in the states where Medicaid had been expanded, the reduction disparity was thought to be about 4%, and this was thought to be statistically significant. So again, potentially addressing disparities, Medicaid expansion is associated with reduced racial disparities in timely cancer treatment. So national healthcare policy may actually impact healthcare disparities. Again, it's a topic that has been brought up in this forum a number of times. There are some study limitations. They did not define the causality between Medicaid expansion and improved access. We don't know what exactly happened to those particular cases where there was a change. We don't exactly know what was done in those states to change that. And again, they didn't look at outcomes. On that timeline, we didn't really look at outcomes to see, is just because you have better access, because your time to healthcare treatment was reduced, did that impact outcomes? And again, that's probably the topic for a later study. So overall conclusions, we're on time. All right, so small cell lung cancer, we have a new frontline standard of care. You need to consider adding immunotherapy to standard chemotherapy with a platinum and etoposide. For pancreas cancer, we now have the first targeted biomarker-based therapy for patients with a new diagnosis of metastatic pancreas cancer. We need to consider doing germline BRCA1, BRCA2 testing for those patients. And as far as the ACA is concerned, electronic health records, again, this is what Flatiron has, is facilitating research to address healthcare disparities. And again, it looks like you can make some important observations from those types of studies, and that, again, could potentially impact, again, healthcare disparities and just healthcare in general. And again, plugging one more time, our annual oncology updates. As I said, if you need to go, if you want to go, I can get you in there. All right, thank you very much.
Great, that was great. Thank you very much for that review. Anybody have any questions? Dr. Colbert?
I think I ask you this every time. It seems to me when you use a toxic agent and then you add a checkpoint inhibitor, it almost seems contradictory, as to the sequence of treating individuals. I mean, wouldn't it make some sense to change the order, maybe using a checkpoint inhibitor potentially before to boost the response to these?
I mean, there have been. It doesn't work in every situation. I would say and I didn't present this, but we do have some recent data from patients with gastric cancers, and this combination does not seem to work. Adding immunotherapy to chemotherapy does not seem to be a productive combination. I do agree with you that giving the chemotherapy up front would make some sense, and then you create the different sort of antigens, and then you do the immunotherapy later. People have looked at that. I don't know that I've seen any big studies on that have shown that it's going to be as effective as just combining them up front. I was surprised myself when the non-small cell lung cancer data came out that, because again, the dogma is sort of, again, you're crushing the immune system and then you're giving something to try to boost it. It doesn't make a lot of sense intuitively. But I would say that it has been a successful strategy. Why these things work, I can't say for sure exactly why. Joe.
So with BRCA and olaparib, if I recall correctly, BRCA mutants are the ones that are also the most mutated in pancreatic cancer. In other words, it's a subset of pancreatic cancer with a higher mutation.
Higher mutation, right? Mm-hmm. That's correct.
And with olaparib, that should increase even further. So I'm wondering if there's anybody tried the others, which is
add immunotherapy to them.
use of PD-1 inhibitor.
I have seen abstracts on that.
Repeat the question.
Okay, so the question was that the BRCA pancreas cancer patients are going to have even more mutations than the usual pancreas cancer patients, and then olaparib on top of that will, because it's involved in the DNA repair pathways, you'll have even more mutations, and so we know that tumors with high mutations are going to be more likely to respond to immunotherapy, and so the obvious combination would be BRCA patients, olaparib, and then adding immunotherapy on top of that. I have seen abstracts on that, but I've not seen any results that I think are that I think we can use that going forward. But that is the obvious experiment to do. Again, it's a fairly small subset of pancreas cancer patients to do. That's about 5%, but that is the obvious next study to do.
Okay, well, thank you, Dr. Lockhart. That was excellent.
All right, our next speaker is Dr. Mariana Khawand-Azoulai. Dr. Khawand-Azoulai is an assistant professor of medicine and the clinical director for palliative medicine at the University of Miami. She completed her family medicine residency at Columbia University, New York Presbyterian Hospital, where she also served as chief resident. She completed her hospice and palliative care fellowship here at the University of Miami in 2014. Prior to becoming faculty here, she served as the lead palliative care physician at the Miami Cancer Institute, where she created interdisciplinary teams to improve palliative care services for patients in the outpatient setting. Her research interests include identifying best practices for end-of-life care for patients suffering from end-stage liver diseases and late-stage malignancies. Please join me in welcoming Dr. Khawand-Azoulai.
Thanks. I don't get a cool headpiece like Dr. Lockhart.
Yeah, you
So.
do. It's right there.
I don't know. I'm good. I'm too old for this new technology. All right, I'm just going to open up the presentation. 1 second. So I'm going to talk today about approach to anorexia and serious illness. In general, everything I talk about is with the palliative care approach in mind, which is a whole person centered interdisciplinary approach. Are you able to see that light green? Is that okay? Okay, good. So my objectives for today, I'm going to define anorexia and identify some secondary nutrition impact symptoms. We're going to review orexigenic medications, which are also known as appetite stimulants. I'm going to explore some non-pharmacological interventions for patients with anorexia and appetite disturbance. In addition, we'll briefly discuss the role for artificial nutrition in refractory cachexia and anorexia. And finally, I'll summarize some counseling recommendations and give you guys some palliative care pearls on how to talk to patients and families about refractory anorexia. So it's loss of appetite, and it usually results in reduced caloric intake, malnourishment, and weight loss. Anorexia is common across a variety of serious illnesses. I most commonly see it in advanced cancer, especially in the outpatient setting, but it's also seen in COPD, CHF, end-stage renal disease, dementia, also advanced HIV/AIDS. So the impact of anorexia is not just weight loss. It also extends to the psychosocial realm. So patients who aren't eating, it causes a lot of distress for not just the patient, but also their family. And because eating is such an integral part of our daily life and the social aspects of eating can be very important for families, the distress extends beyond the patient oftentimes. So patients themselves will have a deterioration in body image if they've lost a lot of weight or a lot of body fat. We know that it causes an increase in depressive symptoms and anxiety symptoms. In addition, there's a decrease in sexual interest and enjoyment, which is another area that we don't really explore a lot in our patients with serious illness. But in studies, patients have reported this. And finally, anorexia, especially at end of life, has been reported to show an increased sense of hopelessness and guilt in bereaved caregivers. So families feel that they could have done more to help their loved one eat. And a lot of times families feel that their loved one died of starvation instead of their underlying illness. So just a word on cachexia. This is outside the scope of this talk, but anorexia contributes to cachexia, which is a loss of body mass, including lean body mass and fat in the setting of a disease state. But the weight loss that we see in patients with advanced illness and with cachexia is not entirely attributed to poor caloric intake. So it's important to keep this in mind when we're talking about appetite stimulants and other treatments for anorexia. In 2007, there was a cachexia consensus conference in order to actually define the clinical picture of cachexia. But the basic summary is it's a metabolic syndrome characterized by loss of muscle, and it's associated with inflammation, insulin resistance, increased muscle protein breakdown, and also associated with increased morbidity. And it is a distinct entity from starvation. So in cancer cachexia, we have a lot more data than in other disease states, but basically this is an infographic to show you all of the things that contribute to cancer cachexia. And these up on top also contribute to the anorexia that we see in our patients. So failure to thrive is another disease state. It's characterized by weight loss, decreased appetite, poor nutrition, and inactivity. And it really describes a point further along a geriatric functional continuum that's closer to full dependence and death. And so anorexia is really a clinical hallmark for both the anorexic cachexia syndrome and for this syndrome, failure to thrive. So back to appetite. What modulates appetite? Many factors go into making us hungry and making us want food. First and foremost, the palatability of food is a big impacting factor, and I have a little picture after this slide to kind of demonstrate that. And that's mediated by the olfactory, glossopharyngeal, and facial nerve. In addition, the feeling of satiety or feeling full impacts appetite, and that is mediated by our autonomic nervous system. Finally, there's a coordination of hypothalamic nuclei in the brain and a vast array of signaling molecules that can either inhibit or stimulate appetite. So the brief section I'll talk about appetite stimulants, we are really targeting these signaling molecules. So palatability of food. I think who in the room would rather eat the tray on the left? Literally nobody, right? And on the right, unless you're vegetarian, vegan, gluten, whatever, but between the two, if you had to choose between the two, I think everybody agrees that the one on the right is better. And that's the palatability of food. So when we have appetite disturbance, we tell people, make sure that the food you're giving your loved one is not, is at the correct temperature, that it's served in a nice way, and that it is appetizing, and that it looks good. So all of these are factors in the brain that can either inhibit a positive or negative effect on appetite. I'm not going to read the whole table for you, but just so you can see that there are many things involved. So secondary nutrition impacts symptoms. When a patient comes to you with poor appetite, it's important to also ask about other factors that can impact their appetite, other symptoms. And so this is a list of some of the examples. So altered taste or dysgeusia. That's how you say that word. I had to look it up. It's not dysgeusia, as a lot of my friends say incorrectly. Depression can also very much negatively impact the nutrition. Pain, xerostomia, which is dry mouth, gastroparesis, and constipation. So some other factors that impact appetite that are important to consider in our patients are medication side effects, namely amphetamines and antibiotics, opioids, and a lot of antidepressants. In addition, food aversions, sex hormone alterations, and age can impact appetite. An example of food aversions is our patients who receive some sort of radiation therapy to the head and neck area, and then spicy food is very painful for them to eat, or acidic food is very painful for them to eat. They can have a food aversion to that. So this is a very useless mnemonic, but I thought it was cool that we could get the mnemonic in with the word anorexia. I don't think anyone is going to bother to memorize this. It's not going to be on an exam. But if you want to be thorough, you can look at this mnemonic and try to figure out every single thing that's impacting your patient's appetite. So the assessment. When patients come to our clinic complaining of poor appetite, we do a very thorough assessment, starting with a history. And within that history, it's important to assess for the secondary nutrition impact symptoms, but also to ask a very good social history. Is there food insecurity? Is this new illness causing such a financial burden that this patient no longer can afford food? Who makes food at home? If it's the patient themselves and now they're very weak and debilitated, they're not getting the same kind of food or quality of food that they had in the past. You want to ask about functional status, ADLs, IADLs, and of course you want to do a thorough medication review to make sure none of their medicines are impacting appetite. On physical exam, weight and serial weight measurements is what you're going to look at, but weight doesn't take into account patients' water weight that they may have, water retention or edema. In addition, you want to look in the oropharynx and make sure there's no thrush or any other symptoms that are impacting their ability to tolerate chewing food or eating food. We want to also look for mucositis. You also look for muscle wasting, ascites, and patient photos. I wrote patient photos here because sometimes this is the first time we're seeing the patient. They're saying, I've lost so much weight, and they may have a normal BMI, and they may not look as cachectic as they feel they look. And so this is an example of that. Do you know who this is? Steve Jobs. Does he look particularly cachectic in this picture? Okay, he does. Okay. If you look at the progression, in 2004, he was looking good. He was actually diagnosed with pancreatic cancer in 2003, neuroendocrine pancreatic carcinoma. So you can see that from 2004 to 2010, he had a pretty significant weight loss, and he does look cachectic. But then in 2011, right before his death, he was profoundly cachectic. And you can see that it's notable from his temporal wasting. But I think that seeing pictures of your patients from before, it can be even more impactful sometimes than just seeing them in real time. This is another example of temporal wasting. So the rest of the assessment, an assessment of dietary intake and use of a screening tool for malnutrition. This is usually reserved for clinical nutritionists. There's not often time, and there's no one universally agreed upon tool to screen for malnutrition, but I just listed them here for you. So moving on to pharmacologic management. So it's important to know that Megace and steroids are the only two clinically proven appetite stimulants. Everything else has insufficient data to support its use. That being said, I will review the most commonly used appetite stimulants besides Megace and steroids. But first, Megace. So the mechanism of action is it's a progesterone derivative. It has progestational and anti-gonadotropic effects. In general, if it's going to work, it should work within the first 2 weeks. And if it's not working to stimulate appetite within the first 2 weeks, then it should be discontinued. And that's because there are a lot of unsavory side effects that come along with Megace, namely thrombotic events. In the clinical studies where it was shown to be effective, the weight gain was only seen in 1/4 of treated patients, and that weight gain actually can take several weeks. So if you have a patient on Megace and they were reporting increased appetite but no weight gain, you would continue the therapy and try to see if they have that endpoint of increased weight gain. It does have modest beneficial effects on overall weight and no effect on overall quality of life, lean body mass, or enhanced survival. That's a good question. So, I didn't put it in here. I rarely use it because I have so many cancer patients. You can start at 160 and you can go all the way up to 800 milligrams daily. And so it comes in a liquid form and there's a pill form as well. It's a little bit costly as in addition. So if a patient's insurance doesn't cover it, then that can be a big barrier. So steroids. In 2014, a systematic review of 8 studies did conclude that steroids improve appetite in palliative care patients with malignancies, but there's no evidence for the use of steroids in anorexia due to end-stage non-malignant conditions. In addition, we all know the pitfalls with steroids, including increased risk for infection, gastric issues, and immune suppression. So in certain patients, a short-term trial of steroids is a reasonable alternative to a trial of Megace, let's say if you're concerned about thrombosis. However, there's no evidence to really tell us which steroid to use, what dosing regimen, what dose to start at. And in absence of a poor prognosis, you starting this means you're either going to start and stop it and remove that benefit, or you're going to put this patient on steroids for life, which has its pitfalls. So next is cannabinoids. Everyone has a lot of hope for cannabinoids in cannabis. Unfortunately, the data is not there to support the use of cannabinoids. So I'm going to split cannabinoids into 2 categories. There's dronabinol, and then there's medical cannabis. So dronabinol is an FDA-approved capsule it's FDA approved for chemotherapy-induced nausea and vomiting, and it's also FDA approved for anorexia related to HIV and AIDS. There are at least 2 trials suggesting that it's inferior to Megace in cachexia-anorexia syndrome. Pitfalls with dronabinol is cost. You can't use it for appetite stimulation outside of HIV/AIDS and have it covered by insurance. However, if you are using it for nausea, especially chemotherapy-induced nausea and vomiting, it will be covered, and presumably you can impact appetite because you're treating the patient's secondary impact nutrition symptom of nausea. Medical cannabis, on the other hand, again, it's not prescribed. It's a Schedule I substance. You need to see a specialized physician, not covered by insurance. And there's really no good quality data for anorexia or cachexia. And, of course, the research is limited by its Schedule I status. Mirtazapine or Remeron, has anyone seen this used for appetite? Okay. So it's an SSRI. It's an antidepressant medication, and it was associated with short and long-term weight gain in otherwise healthy depressed children and adults. We think the mechanism is due to appetite stimulation via effects on histamine and 5-HT receptors. And in one small open-label study, there was a weight gain of about 1 kilogram following 4 weeks of therapy with mirtazapine, and in about 24% of cancer patients. And secondary endpoints were not impressive either. Improvements in appetite in about 24% and improvement in quality of life in only 6% of patients. That being said, if a patient has concomitant depression that you would like to treat and they've got an issue with anorexia or poor appetite, this would be your agent of choice. And taking into consideration that it is an appetite stimulating antidepressant, whereas the other antidepressants can negatively impact appetite. So olanzapine or Zyprexa is primarily an antipsychotic, but we're seeing it used more and more in the cancer setting for nausea. It also blocks serotonin receptors. And in a pilot study, improvements were seen in weight gain and appetite stimulation at 5 milligrams a day when added to Megace. And then in one open label study, doses between 2.5 and 20 milligrams actually attenuated the weight loss of advanced cancer when used as monotherapy. Finally, cyproheptadine. This is a very old medication. It's a first-generation antihistamine. It also has some serotonin antagonism. It did provide weight gain in some observational studies of patients with advanced cancer. And in one placebo-controlled trial, 8 milligrams TID had a mild stimulatory effect on appetite without weight gain. One caveat with periactin, cyproheptadine is also known as periactin, so one caveat is that it's so strongly antihistaminic that it can cause some xerostomia and dry mouth. And so you really want to, if you are using this, you really want to evaluate that side effect and see if that's now impacting the patient's PO intake. It's important to note that the one indication for cyproheptadine in anorexia cachexia syndrome is patients with carcinoid, and we think it's because of because it counteracts the increased serotonin activity. So the meds are not great. So it's really important for us to do some expectation management, not only for our patients, but for ourselves and our fellow clinicians, that these agents predominantly they stimulate appetite, but they will definitely not reverse cachexia in most patients. So just a word on management of the secondary nutrition impact symptoms. I already mentioned this before, but if you're going to be treating these symptoms and targeting them, it's a good idea to target them with things that have appetite-stimulating properties. So, for example, if a patient does present with nausea, you want to use olanzapine. You can use cannabinoids like dronabinol. You want to treat depression with mirtazapine, as I said before, and then you want to treat all of these other issues as you know how. There are some investigational treatments for anorexia cachexia that actually try to target that inflammation and that inflammatory cascade that contributes to the muscle wasting. And I won't go through the entire list, but one of the big ones is thalidomide. And at MD Anderson, they're doing some research now on thalidomide and its impact on anorexia cachexia syndrome. So just as important as pharmacologic management is the non-pharmacologic management. So big thing is really, as I said before, expectation management, counseling for the patient and the family. We do encourage patients to engage in social eating and sitting at the dinner table so that even if their appetite is not improved, they're still engaging in that social activity of being with the family unit. And that will decrease the distress seen by the patient and the family in terms of them missing out on things just because they're not hungry. The pleasure of tasting food should be emphasized over total caloric intake. And in this same vein, it's important to reinforce that there's not enough data to support a low sugar or a low meat diet in cancer. And patients oftentimes are put under a lot of pressure by their families to become vegan when just last week before they were diagnosed, they were eating hamburgers. And so it's important to counsel and guide them that taking in food is more important than the specific food they're eating. It's important to focus on small, frequent meals that are dense in calories. This is also very effective for gastroparesis patients. So if you have that report of early satiety, then you want to really encourage those small, frequent meals. Encourage meals that require little preparation, something microwavable. I tell patients if there's a meal you really like from a restaurant, order a large amount and then freeze it in small aliquots so that you have it accessible to yourself. These little counseling tidbits really make a big impact for the patients. We also encourage resting before meals for patients who have fatigue. And very important in palliative care, but for all of us, we engage in interdisciplinary teams. So nutrition consult, have social work come in. If the patient has trouble getting food or any food insecurity, they can help with that. They can get a meal delivery service for the patient. And then physical therapy and occupational therapy is arguably extremely important as the patient if they have a declining functional status, they're going to have less energy and they're going to have an overall poorer prognosis. And specifically, OT, PT can help them with making food or feeding themselves and their ADLs. Finally, American Cancer Society does have a poor appetite excerpt on their website. It's very well written and it's very useful for patients and families. Does anybody know what this is? Miracle fruit. So this is another non-FDA approved, non-evidence-based suggestion that we can make. It's not a prescription, but it's basically a fruit that when you eat it, it coats your tongue and it makes acidic and bitter foods taste sweet. Unfortunately, anecdotally, I found that my cancer patients don't love this because they don't want everything to taste sweet. But there's a very small subset that may benefit from this, and it maybe in other disease states it might be more helpful. The fruit actually grows in South Florida. It's kind of difficult to grow it. I tried and it died. But you can also buy miracle fruit extracts, but again, these are not regulated by the FDA, so we can't guarantee what's in that miracle fruit extract. So some disease-specific considerations. In CHF, the appetite disturbances and cachexia are actually improved with optimization of heart failure management. In COPD, exercise, Megace, and oxandrolone have been shown to help. In CKD, nutritional supplementation has to be balanced with the need for a low-protein diet. And in HIV/AIDS, although we have dronabinol that is FDA approved, the true therapy for HIV/AIDS, cachexia, anorexia is heart therapy. So just shifting gears a little bit to the anorexia that we see at end of life. It can be associated with a premorbid cachexia anorexia syndrome. It may be part of a failure to thrive syndrome, or it's just an expected feature of the dying process. The cachexia, we see cachexia on a continuum, and it's really the refractory cachexia that precedes death that you see here. So just a word on artificial nutrition. In general, artificial nutrition does not prolong life or improve functional status, and there are, of course, some exceptions. And when we speak of artificial nutrition, we're talking about TPN, PPN, and we're also talking about enteral feeding through an NG tube, gastrostomy tube, or jejunostomy tube. So when is it appropriate? So TPN, PPN is appropriate in highly selected patients like people with a high-grade bowel obstruction and people who have a prognosis measured in months and who also have a good functional status. But it's important to remember that after initiation, the use of this kind of nutrition does need periodic reevaluation. And once benefits are outweighed by excessive harms, it should be discontinued. This is difficult. And that's why when you're starting an intervention like this, the counseling has to be on the front end, that at some point we may stop this if it doesn't make sense anymore. I think that helps. In terms of enteral feeding, it's very controversial. There was a big 2009 systematic review that found no evidence that enteral feeding prolongs life or prevents aspiration, or that it improves malnutrition and its sequela, or that it alleviates symptoms of hunger or thirst. However, there are a lot of limitations to these studies, and on a case-by-case basis, it may be appropriate to use artificial nutrition and support. So, may prolong life in patients with good functional status and proximal GI obstruction, much like the TPN, PPN we talked about. Enteral nutrition is very appropriate in patients receiving chemo or radiation therapy involving the proximal GI tract, also our head and neck patients, because they're unable to take in PO intake. In certain HIV patients and ALS patients as well, it can be appropriate. In terms of quality of life, when there is true hunger and thirst, these methods of nutrition can actually enhance quality of life. However, it's important to note that most actively dying patients do not experience hunger or thirst, and hydration status does not improve xerostomia or that sensation of dry mouth. There haven't been any studies demonstrating improved quality of life through tube feeding, and in some cases, it may adversely affect quality of life if patients are denied the pleasure of eating. This is really in the nursing home population where it's the most relevant. So the difference between having tube feeds and that's your source of nutrition versus somebody coming to the bedside and hand feeding you, there's so much more physical and emotional interaction there that this is why the quality of life is really something to think about when we're talking about tube feeds. So in terms of counseling, you want to tell families and help them, you want to help and coach families to understand that increasing caloric intake does not reverse the underlying process. It's a common symptom, different from starvation, and that it's a natural process occurring at end of life. And these words can be very reassuring for patients and families, mostly families at this point. So, I don't know. Okay. I have 2 minutes. Okay. So just in general, this is an acronym that's actually useful. So approach to discussions of any sort of discussions about goals of care, end of life care, anything like that. So we use the GOOD acronym, which means goals, options, opinion, and documentation. So if we're sitting down with a family talking about the initiation of enteral feeds, we ask them, did your loved one have an advance directive? Did they ever mention their advance directive, whether or not they would ever want artificial feeding at end of life, or would they want heroic things at end of life, etc.? You want to review any patient's previously stated wishes or values. then you want to give options. So informed consent means giving the patient the option for enteral feeding or the alternative, which is no enteral feeding and hand feeding. And so it's important to know that you need to give that option as well. Sometimes patients don't feel that they have that option to not do the enteral feeds. Finally, opinion. You're going to give your opinion as the clinician. You're going to use data. You're going to use the patient's previously stated goals and input from the interdisciplinary team to help guide them to a decision. And then documentation. You want to write down what the plan is so that everybody's on board and that you don't have other clinicians coming in the room saying, "Oh, he's not eating. What are you going to do about that?" So this approach overall is the way that we approach everything in palliative care in terms of goals of care. So in conclusion, MAGACE and steroids are the only clinically proven treatments for anorexia related to serious illness. Appetite stimulants do not improve lean muscle mass or prognosis as of yet that we know of. Clinicians should optimize management of secondary nutrition impact symptoms and other contributors to poor intake. And finally, with rare exception, artificial nutrition will not improve quality of life or prognosis in anorexia related to advanced illness.
Thank you, Mariana. That was an important topic and well discussed, and I can assure you it is on the boards. Questions like in terms of appetite stimulation and so forth in this class of patients. So it's an important topic, and I thank you for covering it for us today at Grand Rounds. Are there any questions? So at this point, I want to conclude Grand Rounds since there are no faculty here, practically. Thank you, the residents, for coming, and the faculty that did show up. And that we will resume Grand Rounds with full attendance expected in September. Thank you. Mariana.
She's here. She's here.
That was great. Thank you.